So we're going to look at big data and how we use it in cataract surgery and how it's helped us over the years. I thought we'd start with a definition of what a cataract is, although you probably all know, and I do intend to show a surgical video of cataract surgery because it'll help you to understand what it is we were analysing and why it was so important. But I will give you a warning to look away if you don't want to know the football scores, so if you feel queasy, just look the other way. And then how we collect the big data and use it in cataract surgery and how it influences patient safety. So that's the eyeball from the side view, and yes, I can use the mouse. So just there is the lens of the eye, this yellow thing. That's inside your eye, and when you're young, it has the ability to change shape and do what's called accommodation, which means focus close. When you're my age, you lose that, and you have to wear reading glasses, which is a shame. But as you get older, the lens becomes can become cataractous, so it goes a sort of browny colour. And sometimes if you leave it long enough, it can go sort of white colour. So you look at someone with a very mature or long-standing cataract, the pupil actually looks white rather than black. And so these are different types of cataracts. They can be quite pretty. That one in the top right is called a Christmas tree cataract. Very pretty. Better not to have it still, but and they're all formed in different ways by the metabolism in the lens changing and proteins cross-linking. It's a bit like dropping an egg onto a hot plate. You know, the clear gel of the egg changes to white when it heats up, and the same sort of thing happens in a cataract. The proteins cross-link instead of being nicely arranged, and they go from clear to being opaque. That's a simplistic way that I understand it. What does it do to your vision? Well, often people complain of sort of washed out colours, a bit of blurring, and the other big thing is that it can cause a lot of glare. So this is a picture taken from my car looking into the sun, and if a person has a certain type of cataract and they do that, they get that sort of view. This is just breathing onto the windscreen, and it simulates what certain cataracts can do. And interestingly, that sort of cataract can leave you, if you're in the clinic in dull lighting, can leave you reading the bottom line of the sight chart. But obviously, if you go out in the sunshine, you can't see to drive your car home, so it's quite dangerous. But your vision is recorded as normal in the clinic, so you're still allowed to drive. So there are some anomalies. And we used to decide who should have a cataract operation by how bad their vision was on the sight chart. This person has normal vision on the sight chart, but they can still drive. So it doesn't work to use visual acuity as the basis for deciding on who should have a cataract operation. There's a very good book called The World Through Blunted Sight by a chap called Patrick Trevor-Roper, who was an ophthalmologist and eye doctor at the Westminster Hospital. And it's worth reading. It's all about famous people and what cataract has done to their eyes. So, for example, if you look at William Turner, his early work is very detailed and very fine detail in all the paintings. But if you look at the later work when he had cataracts, there's no detail at all. I would have kept him off the waiting list because I prefer the later. There's similar stories about Monet. It's not just adults though. Here's a child in the Philippines. I work with a charity called Orbis, which is a flying eye hospital, an operating theatre on a jet. We do land the jet before we operate, so it's quite stable. But this child is, I think, 3 or 4 years old and has very dense bilateral white cataracts, so can see nothing at all, is blind completely. And this is just before his cataract surgery, or her cataract surgery, I think. And really just to make the point that there are, I think it's, the latest figure is 58 million people around the world with that situation, completely blind in both eyes, and another 258 million who are partially sighted from some form of visual impairment. So a lot of people affected by this, and it's a completely treatable condition, but a lot of people don't have access to healthcare in the way that we do here. So it's a blinding condition in those countries. Another example, this young lady's in Ghana, same thing, bilateral dense white cataracts, completely blind, hasn't been able to go to school for 2 years. And an older lady also in Ghana who again has this bilateral dense white cataract. So these people are completely blind. In the UK, the incidence of cataracts is about 6 per 1,000 population. So it's quite common, and it's the commonest surgical procedure that we have in this country and indeed across the world, and it accounts for 4.5% of all operations on the NHS. It also recently accounts for the largest number of outpatient procedures or outpatient attendances in any specialty. So we have the busiest outpatients of any specialty in medicine. Everyone has has two eyes, unfortunately, so that keeps them coming back. You know, they've got one heart, so if that goes wrong, get it fixed and you're fine, but you've got two eyes. So we see lots of people for maybe partly that reason. There's also a reason for showing this map is it shows the, in the upper map, it shows it's called the distorted map of blindness. And the upper map shows where the blindness is and the lower map shows where the ophthalmologists are. So there's a huge mismatch. You can see little Africa in the bottom map, there are very few ophthalmologists, whereas there's a lot of blindness. As an example, we did a project in Zambia where there are 14 million people. Half of them are under the age of 16, so 7 million children, and one paediatric ophthalmologist, so one paediatric eye doctor to serve 7 million people. So there's a lot of need. But despite those numbers, Sir John Wilson, who himself was blinded in a chemistry accident at school, said this: people don't go blind in their millions, they go blind individually, each in their own predicament. And of course, we know that to be true. So everyone has their own problems. Even if you're not completely blind from cataract, it can stop you working or driving or reading or doing things you enjoy. So the principles of cataract surgery, this is a Smartie. You all remember Smarties? And it took me a long time to get that cover off the Smartie, the hole in the middle there. But essentially the cataract, or the cataract's lens in the eye is about the same size and shape as a Smartie, as it happens. And the idea of a cataract operation is to make a hole in the Smartie casing, scoop out all the chocolate and leave the empty Smartie casing and put a new lens inside that Smartie casing. Okay, so you all understand that, it's dead easy. So I'm going to show you an operation here. Look the other way if you don't want to see this. This is actually a bit of a paediatric cataract operation where the front of the Smartie's already been taken off. So you can see there's a hole in the front of the Smartie there. Some fluid is being injected between the chocolate and the Smartie casing to loosen it all up. And once that's been done, then you use a special oscillating needle, which is this thing which emulsifies the cataract and takes it out of the eye. And then another instrument to remove the soft bits that are left behind. So you're then left with this empty Smartie casing. And I'll move this on a bit because the next bit doesn't apply to adults. But at the end of the day, once you've got the empty Smartie casing, you then put a new lens, and this is the new lens going in place, and it's foldable, so it's like a ship in a bottle. You put the lens in and it unfolds into the eye. And that lens is calculated to give the patient good distance vision, and then they have to wear glasses for reading. Nowadays we have multifocal lenses which can do distance, middle and reading. They're not perfect, there are some issues with them, but they're coming, the technology is changing all the time. Now, the reason for showing you that is that one of the big issues in cataract surgery, especially when you're learning it, is that you can get a particular complication where you break the back of the Smartie casing accidentally, and the jelly that fills the back of the eye, remember that diagram of the eye, the main back of the eye is filled with blue, which is jelly. That can come forward into the front of the eye and cause problems. And so that's called posterior capsule rupture, the capsule at the back of the Smartie, if you like, ruptures, and vitreous loss. Now we know exactly where the vitreous is, but it's lost, you know, we call it losing vitreous. And that particular complication is the thing that is the most easily preventable, modifiable complication, which gives us poor results in cataract surgery. So I just want to show you what that's like. You'll see here this surgeon is taking out the remnants of the cataract, and just there, I've freeze framed it. You might be able to see there are some little creases on the back capsule of the eye. You see those striations. So that's the back capsule's been caught on the oscillating needle, and it breaks it. And then as the surgeon takes the instruments out of the eye, you'll see the vitreous coming forward, that bursting through the capsule, the hole in the capsule. So that's a bad thing. And if that happens, then there are all sorts of complications that can occur, like infection and detachment of the retina, which is the bit you need for seeing, all sorts of serious things which we don't want to happen. So moving on to the collection of cataract surgery data, this was really begun in about 2001, when there were 12 units across the UK using electronic patient records, just 12. I think there are 153 eye units in the UK altogether, and 12 of them had electronic patient records. There was an ophthalmologist, an eye doctor in Cheltenham, who wrote his own program called Medisight, and that's now become fairly widely adopted across the country. But 12 units have this electronic patient record, and data was collected between 2001 and 2006, and the minimum data set that was required was some preoperative data, some information about what sort of anaesthetic was being used, details of the operation and complications, and post-operative data. And then that was remotely extracted. This was the important thing. It was remotely extracted by a team in Bristol, anonymised, assessed for conformity and complete the conformity and completeness, and then analysed. And they extracted data from 55,500 records of 406 surgeons. And here's some of the information. We knew then that the mean age for a cataract was 75 and a bit. Most were female. Partly we think because females were living longer in those days. I think they still are. 95% were under local anaesthetic, so you weren't put to sleep. You just had an injection by the eye. And maybe alarmingly, trainees were performing a third of all these operations. Maybe that doesn't alarm you. It alarms me. But anyway, and the posterior capsular rupture rate was nearly 2%. So 1 in 50 cases, we were getting that complication that I showed you from around the country for all grades of surgery. It was higher for trainees, lower for consultants, which I think you'll agree is the way you'd want it, but essentially about 2%. So what this team did was they analysed all the factors which led to an increase in this complication. And it's interesting, so even the top one, the inability for the patient to lie completely flat, gives you a slightly increased risk of a complication because the surgeon is at a slightly awkward angle, patient might be uncomfortable, they might move, and it's not a big increased risk. The adjusted odds ratio is 1.27, so not much worse than normal, but certainly slightly worse than normal. And you go down the list, you see males being of male gender is a slightly higher risk. Men have always had a harder time in life than women, as you know. The presence of other diseases or a small pupil, various things. And you'll see that right down at the bottom, trainee surgeon, nearly 4 times as likely to have this complication than an experienced surgeon. Now, you can use that table of adjusted odds ratios to work out what the risk for a particular patient is simply by multiplying together any of those factors that a patient has. So, for example, on this graph at the bottom is the odds ratio, and we have an example of a patient who's female, 90 years old, and has a consultant surgeon doing the operation. You multiply those risk factors together from the table that I showed you, and it comes to 2.37. You look up 2.37 on the graph, and you go along to this axis, and you get the predicted probability of that complication occurring. And in this particular case, it's 1.7%. So you think that's not bad. 90-year-olds, it's not a bad risk. You do the operation. But what about if it's Friday, you're the junior, you're operating alone, which actually we don't allow. It's a male patient, more than 90 years old. They've got all these other things, which, believe me, are risk factors, and they can't lie flat. And you multiply all those things together, and you can see that the odds ratio of that person having a complication is 44%. So this person is almost as likely to lose vitreous, as we call it, than not. So suddenly you know that this is a high-risk case, and you might say, well, okay, I'll give that to an experienced surgeon because we don't want that complication to happen. It doesn't guarantee it won't, but it's less likely. A colleague of ours called Tom Butler in Great Yarmouth published this paper in the Journal of Cataract and Refractive Surgery. I recommend that if anyone's having difficulty sleeping at night. But no, it's a good journal, and he developed a scoring system based on that table such that you could assign a number to each of the risks, and we incorporated that into our cataract pre-op assessment form. So each of these here is the risks that I was showing you down that table, and each one has a number by it, which is the score, the relative risk score. And what we decided was that if the score was 3 or more, a consultant surgeon had to do the case to lessen the risk of a complication happening. Did it help? Well, we analysed 27,000 cataracts over a 6-year period, 3 years before we introduced the risk scoring and 3 years after, and it showed quite clearly that it made a big difference. We reduced our complication rate by 20% simply by analysing who was a more risky patient than another. And there's the graph showing that. For the trainee surgeons, you see that their complication rate went right down after the introduction of this scoring form, simply because we were giving the right patients to the right surgeons to operate on. I think it had another facet to it as well, in that if I read the patient's data and I saw that they had a score of 9, I suddenly knew that this was a high-risk patient and I did it much more carefully. Whereas if you didn't know that before you started, you dive in and you do the operation not expecting trouble. So it makes you more cautious as a surgeon as well. I think that's an added benefit. Since then, the latest report was 2020 and 20 to 2021. We now have 134 centres collecting data, mainly because there was a company that sponsored every eye unit in the country being gifted this module for a year to collect all the data. So a lot more centres got the programme, and it shows that the posterior capital rupture rate now nationally is about 0.9%, so it's dropped by a full percentage point really. With more than 70% of the patients now participating in this audit, it's now on the quality accounts list, and it means all NHS trusts in England are required to participate in their annual report to the Secretary of State for Health. So it's had this huge benefit of suddenly people up there knowing what's going on in each trust in terms of complications. Can I tell how well I'm doing? You can plot a funnel plot like this, and this tells you along the bottom the expected number of cases of posterior capital rupture for the case you're doing versus the actually observed number up the side. And what you want is to be right down at the bottom, in the corner, bottom right-hand corner here, doing lots of cases with no complications. Unfortunately, there are some people up here who are doing fewer numbers, as you might expect, getting much higher complications. So for the first time, you can now go into this chart nationally, click on a dot, and you can't, but I can see what I'm doing. It was very useful for me because I retired from clinical practice in 2019. I then organised for a global pandemic to happen, and came back to work 8 months ago to do some cataract surgery to help catch up with the backlog, and then retired again 2 months ago. But what was interesting is while I was back at work, I thought, well, I'll just go and click on the dots to see where I am to make sure I haven't slipped, and they don't say, well, Benjamin's gone useless, he should go. And I was clicking about in the bottom right-hand corner, as you do, thinking, well, you know, my posterior capital rupture rate used to be 0.3%, that's not bad, I'll just see where it is. And I clicked about, nothing happened, and my name wasn't coming up, and I got further and further and further up the graph until it hit 3%. Now that's a sort of chuck-outable offence almost. So I looked into it a bit further, and now fortunately the programme tells you which patients these numbers relate to. And I pulled out all the ones that it said I had this complication for. And it turned out that what was happening was if you were entering the data electronically and you hovered for slightly too long over a particular place on the screen, it ticked the box that said posterior capital rupture coincide. In fact, it was 0.3%, but it was telling me it was 3%. Such is alarming, but it was reassuring that we sorted it out. So in summary, data collection, I think, is vital in understanding and maintaining standards. EPR is very valuable in speeding up this data analysis. I remember a colleague of mine once did a similar project analysing outcome data in Moorfields Eye Hospital. We had one registrar collect notes from the basement of the hospital and analyse 45 patients for a particular outcome. And he had another one do it electronically on their electronic patient record system. One took, I think, 17 hours of going through the papers and marking things down on Excel and analysing them. The other took 10 seconds. So very valuable to be able to make this electronic and to track our outcomes and maintain standards. We hope that the work I do with Orbis, the reason for showing you this view from around the world, that we can incorporate something like this onto the Flying Eye Hospital, because for the first time it will give us global data about standards of surgery, but again about blindness and what's happening to who, what the outcomes are, and how people are benefiting. Thank you very much.
Hi, my name is Mike Adams. I'm an ophthalmologist in Buckinghamshire. I work at Stoke Mandeville Hospital, where I am co-lead of the eye clinic and also lead for cataract surgery. So I'm here to talk about Dora. Dora is our AI system that delivers post-op phone calls to our cataract patients. I have no financial interest, more's the pity, in the contents of this talk. So we're all really grateful that cataract surgery has moved on from this lovely painting, which I found in a chapel in Salvador in Brazil. This patient is being couched, where you stick a needle into the eye and wiggle it round until you pull the cataract out of the eye, dislocate it inside the eye, and then the patient can see out again. But as you've seen from Larry's videos, things have moved on quite a bit since then. We now have shiny new cataract units. This is our shiny new cataract unit. I helped to design this with one of our commercial partners, and the idea was to build a modular unit optimized for patient flow. And this is the unit, in fact, that Larry's been operating in with us, doing high volume cataract surgery, where we do sort of 16, 20 patients a day in a unit that's designed to keep people safe through COVID. And it meant that we were able to restart cataract surgery just 6 weeks after the first lockdown. And in 2021, we were the most productive cataract unit in the country, doing more cataract operations even than Moorfields and City Road. We also have slightly less shiny surgeons who do things like wear gloves and masks and scowl at people who take their photograph in theatre. And yet, despite all that, we're all too aware of graphs like this showing that patients are waiting a record number of weeks for surgery. So why is it that despite our shiny bits, patients are still waiting ages for treatment? Well, the answer in part is that that statistic of 18 weeks, more than 18 weeks, hides the fact that there's two parts in the patient journey. There's the point from referral to their initial clinic appointment, and then there's the point from clinic to theatre. Now, for us at Stoke Mandeville, if you're referred for a cataract operation, you'll wait probably 6 to 8 weeks for your clinic appointment, and you'll then wait a couple of weeks to get into theatre. And for many units around the country, those figures are even bigger. The reason for that simply is that whilst our cataract surgery and other surgical things have evolved, our clinics haven't. And Ruben's painting just makes me think of an outpatient clinic. So here's someone who definitely has an eye problem. You can see his eyes sort of rolled up in his head, but this lady needs paediatrics, not ophthalmology. And I think this chap needs a coroner and not a doctor. Our clinics aren't quite that bad, but heterogeneity in clinic is always a difficult thing because it makes you less efficient. So for that reason, every eye clinic has triage, and we try to stream our cataract patients to a cataract specific clinic. Here we have our patient pathway, which we drew up a few years ago, essentially just a process mapping exercise looking at the whole patient journey from initial referral to discharge, having had both eyes done, because most patients have 2 eyes. The average number of eyes in the country is about 1.9. So we looked at that process map and tried to figure out how we can improve the through flow. So we have that initial delay from referral to cataract one-stop clinic, and then we also have a second interaction with our patients at the post-op check. About 15 years ago, hence the slightly dated-looking PowerPoint slide, I wrote a presentation as a trainee down on the South Coast. I'd obviously had a bad week and was feeling a bit grumpy. Do we need to see them? And what I did was create a questionnaire that our nurses could use to phone up patients after their cataract operation and see whether actually we needed to bring these patients into clinic at all. This was a little pilot. I think we had 50 patients or so, and was positively received. And so at Stoke Mandeville, more recently, we looked to see whether we could do the same thing and stop seeing our patients post-op. I just recycled this questionnaire and gave it to our senior nurse consultant, who has 30 years of nursing experience. And she came back a few days later, slightly grumpy, and said, I phoned 250 patients and only 7 needed to come in and be seen. That's then 243 appointments, which can be recycled to being your first appointment rather than your last one. So an immense saving and an acceleration of that first chunk of the pathway. As with any task that is highly stereotyped and quite repetitive, it's ripe for automation. So enter Dora. Dora is an autonomous telemedicine assistant developed by a company called Euphonia, which is an Oxford University spin-off company. My relationship with Euphonia started in 2018, where I supported them in their interview with the Innovate UK panel to get their initial funding. Since then, they've interacted with all these different organisations to develop a programme, and if I can get the technology to work, this is what she sounds like.
Now, let's get started. I've just got a few simple questions about your eye. First up, is your eye red?
Yes, it's a little red.
Okay, is it just red in the corner by the nose, or is it red all over?
Just in the corner.
And is the rest of the eye completely white?
Yes, it is.
So a pretty simple little clip there and an example of what our patients experience when Dora phones them up. I now need to get back to the original thingy bob, and Larry did show me how to do this on his Mac earlier. Go. Is that looking about right? Yes. I think so. No?
Still showing the video.
Still showing the video. Hang on a second.
The point of the redness, were you going to say this, Mike? The redness in the corner is that's where you do the injection for the anaesthetic, so it's often a bit red in the corner. Which is why they asked that question.
Right. Sorry, the screen share thing is a bit clunky.
That's it.
Yeah. Not quite. Yeah. It's quite a simple conversation, but it demonstrates how Dora is analysing the patient's response and taking the key phrases from that response to then fine-tune her subsequent questions. And that means that it has the ability to interrogate a patient and work out, is that something that's serious and needs flagging up to a human, or is that actually part of the normal post-op process? So Dora now is a CE/CA marked Class 1 medical device, software as a medical device. She has the relevant certifications that these devices need for use in the healthcare space, which probably some of you helped to write, for all I know. And she uses something called natural language understanding, which has a fairly straightforward speech-to-text conversion. The text is then broken up into little chunks, which these guys call tokens, and then those are passed through the algorithm that allows Dora to figure out, do I need to ask a follow-up question, or can I draw a conclusion straight away from those tokens? All of this has been done linking up with the University of York's Assuring Autonomy system. These people have a fairly standardized and robust framework for machine learning, which just helps to reassure all of us that these systems are learning sensibly and operating safely. That's about all I understand about what's under the bonnet of Dora. And people smarter than me do all the coding stuff. But for me as a clinician, this is the really important bit. So the General Medical Council publishes its Good Medical Practice document, which is essentially the set of rules by which doctors have to practice in the UK. And one of the paragraphs is this key phrase: if you're delegating patient care to someone else, you as the clinician are responsible for making sure that the person to whom you delegate that care is able to deliver it safely and effectively. Or in other words, if I'm asking a machine to phone my patients, I need to be sure that the machine knows what it's doing. All those frameworks that go into the manufacture of Dora and other AI systems help to reassure me as a clinician that my patients are safe and that I'm fulfilling these requirements, which are a necessary part of my registration as a doctor. So, deploying Dora then, we did in our high volume cataract unit for a couple of reasons. Partly because of the numbers of patients we get through, which would ensure a good data return for the pilot projects and the subsequent implementation of Dora. And partly because the cohort of patients we treat in this unit are similar to the kind of patients who are suitable for a Dora phone call. So they're adults, they're straightforward surgery, they have capacity to give consent, they have access to a telephone, and they're able to have sufficient English for a phone consultation. And that pretty much matches our high volume cataract patients. So our patients who have significant cognitive or linguistic impairment are not operated on this suite, but are taken to our main eye theatres where we can support them more through the journey of surgery. That matches up quite well then, and we're able to deploy Dora, and this is a sort of map of the conversation she has with the patients. So an initial authentication, just confirming it's the right person with name and date of birth, an exploration of the patient's symptoms, a question about whether they'd like to go ahead with surgery for their second eye, if that's relevant, and then some feedback, both for the hospital and for Dora as a system. And all of that was then added up into a net promoter score for the first 170 calls. And the mean net promoter score was 8.6. Now, for a piece of new technology being tried out on a population with an average age of 75, I reckon that's a pretty good net promoter score. What's the reason for that? Well, the reason, I think, is the asymmetry of the technology. All the clever stuff is on Dora's end. All the patient needs is a telephone. There's no website to log into. There's no app to download. There's no password to forget. There's no tablet or smartphone to have to use. Anybody with a phone line can use this system. And so this is really a way of hiding all the clever stuff and just keeping the patient interaction as simple as possible, just a phone call. We got lots of feedback from our patients, and I put these up verbatim, just because I think it's really important that we understand how our patients interact with changes like this. Over the last few decades, medicine's taken quite a lot of strides to move away from the old school paternalistic approach of I think you should have this drug or this operation. But we're often a little bit guilty of making that same sort of paternalistic mistake when we deploy new technology, and engaging with our patients and figuring out how they feel about it is really important. Our feedback fell into three main themes. The first was, I can see why you're doing it, because the NHS doesn't have the time, money, staff to make essentially a routine phone call. This chap's feedback was so eloquent, I put it up in full. This guy says, it's a wholly unnecessary exercise to get up and get in the car, aim to be at the hospital at a certain time, find a parking space and all that goes with that, just to see at the doctor's office, you have no side effects at all, and you say, okay, thank you very much. That for me sums up the whole reason for this project. The second theme was slight surprise that it went quite well. Patients naturally were a little bit nervous about this. They were told that they'd be called by a machine 3 weeks post-op. And yet all of our patients were pleased to see how well the interaction went. They also understood that we do need to embrace technology and look to do things differently. And the third theme, perhaps inevitably, was a slight sense of remorse at the loss of the human interaction that they'd experienced before, even though for about a year beforehand, that interaction was a nurse on a telephone rather than a computer on a telephone. People were clear that despite Dora's naturalish voice, despite the fact that we've given it a name, this was definitely a machine and not a person. And they did feel that they missed that human interaction. So for us, Dora's the new normal for our post-op cataract patients. Various papers and posters and publications at national and international conferences where she's won various prizes. But we're always looking for the next thing. So she's helped with our post-op calls. Well, what about that pre-op Rubens clinic? How can we get Dora to help in that part? The cataract clinic's got three components. The first is the nursing assessment. Hi, how are you? What's your blood pressure? What medicines are you taking? What are you allergic to? Then there's the doctor assessment, which is let me have a look at your eye. Is there definitely a cataract? Is there something else? This is the operation. These are the risks. Are you happy to go ahead? And lastly, there's the measuring of the eyeball to make sure that the lens we put in is the correct power for that patient's eye. Now, obviously, that last bit does require a physical conjunction of eyeball and machine, but the other two bits can be delivered remotely. We've been delivering the nursing assessment remotely for a little while by telephone, and we're just piloting now delivering the doctor bit remotely as well. That's happened slightly organically. The rules around pregnancy and working in the NHS are quite strict still because of COVID, and so we have a couple of senior trainees who are due to go on maternity leave who've had to go earlier because of the rules around COVID and pregnancy. What that means is we have two really experienced doctors who are sitting at home and bored, and that's a perfect opportunity for piloting a new system. So the patient comes in, has their measurements done, the nurse does the pre-op by phone, and those doctors are able to access all that information remotely from home, look at the images, look at the measurements, phone the patient up, and talk them through the clinic process. Of course, if you can do that safely with a human on the phone, can you also do it with an AI system on the phone? We think so. And so once we've proved that it's safe to do with a human on the phone, we'll then move to do this with Dora. There is the slightly frightening prospect that Dora could then phone all 600 patients on the waiting list at 4 o'clock on a Sunday afternoon, talk to them all at the same time, list them all for surgery, at which point I'll need more operating theatres. Nice problem to have. A buzzword in the NHS at the moment is PIFU. PIFU stands for Patient-Initiated Follow-up. For centuries, doctors have believed that patient symptoms synchronise with the rotation of the Earth around the sun, and therefore say, come back in 6 months and we'll see how you're getting on. Obviously, that's nonsense unless it's seasonal allergic conjunctivitis. And it's really good if patients can access healthcare when they need it, and it's really good if they don't come to hospital if they're absolutely fine. If you have well-controlled asthma, you don't need to be seen every 6 months to be told you still have well-controlled asthma. But if your asthma becomes uncontrolled, you need access quickly to an asthma clinic. And that's the idea behind PIFU. It's not brilliant for eyes. A lot of eye conditions can't easily be monitored by the patient themselves. And the condition glaucoma that Larry mentioned earlier on has no symptoms at all until it's too late to do anything about it. And so it's not great for those chronic conditions, but it does potentially have use for post-op. And so one of the things we're looking at with Dora is, rather than Dora phoning the patient phoning Dora. We give the patient a phone number to call at the end of their op and say, give us a ring in 2 or 3 weeks and we'll just check you're okay. If the patient forgets, Dora will phone them anyway. If the patient phones after 2 days, Dora will say, well, this is a bit early, is everything okay? If everything is okay, they can be reminded to call back later. And if it's not, Dora can analyse that conversation and pick up the red flags and pass that on to a human so we can get that patient quickly into clinic and see them if we need to. I think more exciting than PIFU is the potential for Dora to speak different languages. So Buckinghamshire's got quite a diverse population. Our patients speak a whole raft of languages, not just Polish, Urdu and Gujarati, but all sorts of other languages as well. We know that poor English in the UK is linked to poor healthcare. And we have lots and lots of patients in that 75 average age category who don't speak English as their first language, who are either first generation migrants or have come over subsequently to join family members. Imagine then if my 76-year-old Bangladeshi patient who doesn't speak English as the first language can phone up Dora, can talk to her in her first language. Dora can reply, can pull out key phrases from that conversation and flag that patient up as someone who needs to be seen. The other thing about this is that quite often these patients are accompanied by family members who are either of working age or of school age, taking those people out of work or of school to ensure that grandma gets to see the cataract clinic. Dora potentially can leave those people in work and in school and still deliver the same quality of healthcare. So this, for me, I think is really exciting. So we're currently teaching her to speak Polish. Beyond our bubble of Buckinghamshire, there's other roles for AI within healthcare. We know that the UK is the poor man of Europe when it comes to numbers of doctors and nurses per patient. That's not a new problem. These things don't happen overnight. The Royal College of Ophthalmologists 4 years ago pointed out that we would need an additional 200 consultants over the next 2 years, so by 2020, to make sure we had the right number of consultants for patients. That obviously hasn't happened. Training posts in the UK are rationed and controlled by Health Education England, and just this year we had over 800 applicants for only 80 training places. It takes 7 years to turn somebody from a trainee into a fully qualified ophthalmologist, and so this is not a problem that's going to go away quickly, and small wonder that Teresa's latest plan has been met with a fairly muted response from most of the Royal Colleges. Dora can help. She's not cheaper than a nurse, and in fact, in terms of pence per call, she's more expensive. But by doing those routine and stereotype tasks, Dora frees up our nurses to do other things. Our clinic nurses do all the sort of stuff you'd expect a nurse to do, put in eye drops, give out tablets, check vision, but they do things you might not expect a nurse to do, minor eyelid procedures, injections into the eye for the treatment of macular degeneration. And so our nurses are significantly more skilled than you might expect. That's good for them, gives them a feeling of career progression, and it's also really good for retention within the NHS. And of course, if nurses are doing that stuff, it frees up doctors to do other things as well. And so that's really where the benefit of these AI systems comes in for the financial side of healthcare. It's not really what they do, it's what they mean other people can do. It's not all rosy. This is a news story from today. This chap tragically died after 4 telephone conversations, not with an AI system, but with human beings. And one of the problems with telemedicine is that it's not the same as examining the patient. Our whole premise of healthcare in the Western world is based upon one human next to another human talking and examining. And if we're in clinic and chatting and you say, oh, I've got this funny feeling here, the barrier to a physical examination is very low. If that conversation is happening on a telephone, the barrier to examination is much higher. And that's when you end up missing things and making misdiagnoses. And so this is something that obviously we need to be aware of in the deployment of AI. Solicitors very much are aware of this. And a quick Google shows you a whole raft of solicitors who are very much aware of this as a potential risk. When our AI works well, it blurs the boundaries nicely between hospital and home healthcare. And the vision from Euphonia is that Dora and systems like it really will be a single point of contact for patients, essentially a concierge through their health episode, whatever that might be, pulling in different strands of expertise when needed, but from the patient's point of view, they're interacting primarily with Dora. that is essentially recreating the old family doctor role that we used to have, and I slightly share that remorse that we saw from our patients earlier, that we're losing that human contact and replacing it with a digital solution. And yet you can make a DORA much more quickly than you can make a consultant or make a GP. And so it's perhaps inevitable we're going to see that digitization. It also allows us very quickly to apply the data, the things that we learn from big data, that Larry's already spoken about, to individual healthcare. Normally, dissemination of learning is done through conferences, through papers, through posters, through podcasts, and doctors are quite resistant to change, normally for good reasons, because they feel they're doing their best for their patients and they don't want to gamble by changing their practice. But if, for example, we learned there was a new side effect from cataract surgery we didn't know about before, Dora tomorrow can phone all of our patients, the 5,000 or so that we do every year, and check with them that they're all okay, and can immediately add those kind of questions into the post-op follow-up. So it's a very quick way of applying those learning points. So that's Dora, that's the clinician's view of AI. It's lovely to once again have Buckinghamshire at the front edge of applying technology to national problems. Thank you very much.
Thank you, Mike. I take it happy for
Yeah, of course.
questions.
Absolutely.
Anybody want to kickstart? Brian.
So the front side of that is actually awesome, and you were saying about the potential risk of complications that aren't picked up. Is there like a follow-up process just to make double check on the patients?
So the way that Dora was deployed was in a very layered way. So initially, we essentially took the questionnaire that I wrote 15 years ago and then gave that to Dora to ask patients, and we refined that as medicine's moved on, and I'm hopefully a little bit wiser than I was 15 years ago. But the first several hundred phone calls that Dora made as she was going through that loop of machine learning were listened to in real time by a human at the same time. And so we're still at that stage to some extent. The calls are recorded and then monitored. So she's not fully off on her own yet. She is a level 1 autonomous device. She's not self-driving car. And so we're still tinkering around with that. But eventually, the idea is that she'll fly solo. And we are confident enough in the questions that we ask that we will pick up any red flags. Cataract surgery is quite stereotyped. There's a limited number of things that can go wrong. And there are a few key questions that you can ask. And if your patient gives the right answer to those questions, you can be confident that they haven't got any problems. At the same time, patients are given a phone number to call if they have an acute problem. Generally speaking, the horrible complications happen within the first 2 or 3 days. And so patients know that if they get a problem within that time period, they can phone up our eye emergency clinic. So there is that sort of safety blanket for the really urgent ones. The risk of that kind of complication is tiny. It's 1 in several thousand. And so the vast majority of our patients will absolutely be suitable for an AI call. Yeah, but there is a safety blanket there for the ones who have problems.
Thank you, Mike. Thank you, Larry. That was a very insightful conversation.